morning everyone. My topic is correlation between diabetic peripheral neuropathy detected using the Toronto Clinical Neuropathy Score with glycemic variability in diabetes mellitus patients. So, distal symmetric polyneuropathy is characterized by progressive sensory impairment due to small and large fiber dysfunction, often remaining asymptomatic until advanced stages. So, diagnosis of this relies on clinical scoring systems like the Toronto Clinical Neuropathy Score, the Michigan Neuropathy Score, and assessments like the vibration perception threshold and nerve conduction studies. So early detection through effective screening and strict glycemic control is essential in reducing the risk of ulceration and later lower extremity amputations. So the objectives of my studies were to find the correlation between the severity of diabetic peripheral neuropathy as detected by the Toronto Clinical Neuropathy Score and HbA1c in patients with diabetic peripheral neuropathy. And the secondary objectives were to find the correlation of age and the correlation of the duration of diabetes with the severity of neuropathy as detected by the TCNS score. Now the materials and methodology, it was a cross-sectional study, and the study population, it was a hospital-based study on diabetic patients attending the PMR OPD at AIIMS Bhopal, and it was a 5-month study lasting from September 2024 to January 2025. Now the inclusion criteria, diagnosed cases of type 2 diabetes mellitus and diabetic peripheral neuropathy confirmed by nerve conduction study, patients aged more than 18 years and patients who had given informed consent. The exclusion criteria, patients who had peripheral vascular disease were excluded, patients who had diagnosed with other causes of peripheral neuropathy like Hansen's disease, deficiency conditions, alcoholism and toxin exposures were excluded, diagnosed cases of radiculopathy and inherited peripheral neuropathy cases were also excluded. Now the sample size was calculated based on Fisher's Z transformation. It was calculated based on a previous study by Hunaifi et al. And finally we got the sample size as 47. Now the operational definitions. So the Toronto Clinical Neuropathy Score has symptom scores, sensory test scores and reflex scores. The symptoms we ask the patients are 6. We ask for foot pain, any numbness in the foot, any tingling sensation, weakness, ataxia and all these symptoms in the upper limb. That's the 6th point. And if any of these are present, we give 1 mark. If it's not there, we give 0. Now in the sensory, the points we check for with the tools are, we check for pinprick sensation, we check for whether the patient is able to differentiate temperature, light touch, vibration perception and position sense. And again, if it's abnormal, we give 1 mark. And reflexes also are checked in the lower limb, both sides, knee jerk and ankle jerk. So for both sides, 2 marks are given if it's absent, and the total TCNS scoring is done on 19 points. And the severity of neuropathy is graded like this. So if the score is 5 or less, there is no neuropathy. 6 to 8 means there will be mild neuropathy. 9 to 11 is moderate neuropathy, and 12 to 19 is severe neuropathy. Now the steps of the study, first the patients were selected after applying the inclusion and exclusion criteria. After that, nerve conduction study were done on the patients, both lower limbs and upper limbs, to confirm diabetic peripheral neuropathy. The nerves taken were the sural nerve, superficial peroneal nerve, tibial nerve, and in the upper limb, median nerve, ulnar nerve, motor and sensory. After that, the demographic data and blood tests were done. And after this, the Toronto Clinical Neuropathy Score were applied to the patients who were confirmed to have diabetic neuropathy with the nerve conduction studies. Now when we got the data and applied the statistical analysis, so the variables we got from the patients were age, the duration of diabetes, height, weight, BMI, HbA1c, FBS, PPBS and the TCNS score was also obtained. So when we look at the description, significantly, when you compare females, there were 17 females and 30 males and totally 47 participants. The statistical difference were found in height between males and females and the FBS and PPBS. However, there was no difference in the HbA1c and also the TCNS score between males and females. and the number of patients that we got in each group of neuropathy based on the TCNS score. When we applied TCNS score to patients who are already had diabetic neuropathy, we found that 11 patients did not have neuropathy because their score was less than 5 out of 19. Then 16 patients were found to have mild neuropathy, 15 had moderate, and 5 had severe neuropathy. And when we correlated this TCNS score with other variables, we found that only the duration of diabetes was had a significant correlation with the TCNS score. HbA1c, which was our primary objective, did not have a positive correlation with this, and fasting blood sugar, age, postprandial blood sugar, none of them had any positive correlation with this score. And we found that TCNS score is directly related to duration of diabetes with this formula. So if there is an increase of 1 year in the duration of diabetes, it actually increases the TCNS score by 0.179 on an average. So and this increase is statistically significant, and no other variables contribute significantly to the scores. And the distribution of duration of diabetes among patients with different grades of peripheral neuropathy is classified. So in this box whisker plot, we can see that as the duration of diabetes as given on the y-axis increases, the severity of neuropathy also increases. Now the salient findings were that the duration of diabetes seems to be the most significant variable associated with peripheral neuropathy, because an increase of 1 year in the duration increases the TCNS score by 0.179. And other findings were that 23% of the patients did not have any neuropathy, 34 had mild neuropathy, 31.9 had moderate, and 10.6 had severe neuropathy. Another finding was that males and females, they differ in their blood sugar levels apart from their height. And the conclusion was that our study found no significant correlation between HbA1c levels and the Toronto Clinical Neuropathy score, suggesting that glycemic control as measured by HbA1c alone may not reliably predict the severity of diabetic peripheral neuropathy, but a statistically significant correlation was observed between duration of diabetes and TCNS score, highlighting the role of chronic hyperglycemia and the progression of neuropathy. And there was no significant correlation between age and severity of neuropathy also. These findings emphasize the importance of early screening and regular neurological assessment in patients with long-standing diabetes. A future scope of the study is that we may explore the association between this score and alternative markers of glycemic variability like continuous glucose monitoring data or fructosamine levels, and longitudinal studies with larger sample size could also provide deeper insights into neuropathic progression and its multifactorial contributions. But the limitation was that, last slide, the study was limited by its cross-sectional design and relatively small sample size, which may restrict generalizability, and additionally reliance on HbA1c as the sole marker of glycemic control may not fully capture the impact of glucose fluctuations on neuropathy severity. These are my references. Thank you.
Krishnan.
Sweating and all.
Yeah. C or C sympathetic is the postganglionic fibers to sweat glands. So absence of sweating. So dryness of body is the first symptom. That is not included in this. All the other are presentations as a result of the dysfunction of larger fibers, myelin fibers. So I think it is a late score. So you are losing that patient in the initial stage.
Matthew sir has got.
The duration of diabetes was positively correlated to severity of neuropathy anyway. You knew that. It's nothing new. But you're now trying to, I hope that's what you're trying to say, or not. I think that's what you're trying to say, that severity of diabetes or the level of control of diabetes doesn't matter. That's what you're trying to say just now.
We should not look at HbA1c alone.
Yeah, but it may be better to say that your sample size is really small, so you can't make those conclusions. You understand? So you can't logically say control of diabetes doesn't matter in neuropathy. It does matter. The other point that you raised is already known. You understand? Thank you.
Dr. Helana, neuropathy. So that included in the study. So in the study, using that questionnaire, you found that 1/4 of them did not have neuropathy. So did you take the patients who had electrologically proven neuropathy as those patients with neuropathy or without neuropathy for analysis?
For analysis without neuropathy, because
Without neuropathy. So why was it done like that?
because actually the score.
So is it actually like sensitivity of this questionnaire, whether you are analyzing the sensitivity of the study or not?
This study we didn't analyze the sensitivity.
So you took them as without neuropathy. So it may produce false results in your study, because as sir said, diabetes control is essential, we think, not only the duration. Thank you.
Very good presentation by you, but you had a pretty long period of study, 12 months.
5 months.
5 months. And this glycemic variability, that is the most important crux of the presentation. Have you seen what drugs they are taking now for diabetes?
Drugs. Majority they are taking oral hypoglycemic.
Which group?
With DPP4.
This glycemic variability is overall discussing all medical specialties. I think everyone using this GLP-1 and SGLT inhibitors.
Mainly.
You got to see. So there is a much debated topic now. Glycemic variability is the base of most of the metabolic diseases other than diabetes. Okay.
What is this? Okay. Excellent presentation.